afternoon, everyone. My name is Kalla Gervasio, and I'm the Oculoplastics Fellow here in St. Louis. So I'm training with Dr. Holds in his practice and Dr. Couch and Dr. Mamari at WashU. And I'm happy to be here today and to meet all of you. So I'm going to be speaking about the effect of alternate toxin concentration in blepharospasm therapy. I have no financial disclosures. The objectives of my talk are to discuss the risks and benefits of using what we call double concentration botulinum toxin. And so in our practice, that means using 100 units of Botox per every milliliter of saline that it's mixed with, versus what we've been defining as regular concentration in our practice, which has been 50 units per every milliliter. We're going to review some preliminary results of the use of double concentration Botox for blepharospasm in our practice, and we'll explore some of the patient-reported side effects, duration, and efficacy compared to quote-unquote regular concentration. So, what is the traditional concentration that we've been using? Dr. Couch touched upon this a little bit already, but in the package insert for Botox, there is this nice chart that tells you how many units are you going to have per every 0.1 milliliters of the bacteriostatic saline that it gets mixed with. So as we've discussed already, it comes as a protein, and there's usually 100 units per Botox vial. And traditionally, we're mixing 2 milliliters of bacteriostatic saline to form the solution, and that's going to give you 5 units for every 0.1 ml. Or, if you're using a 1 milliliter syringe, there's 50 units total in that whole syringe. So we wanted to look into, how would people respond if we are using 1 milliliter of saline to mix the solution? And that ends up giving you 10 units for every 0.1 ml, or 100 units for a 1 milliliter syringe. And Dr. Holds has used the traditional 50 units for every milliliter syringe for over 30 years since he started practicing. So this has actually been really what he calls the only major change in his practice most recently over the past year, is to trial this double concentration for his patients. And I'd say in our practice, we're treating anywhere from 30 plus patients a week with blepharospasm. So I'm just going to go through a couple studies that are out there on this topic. To be honest, there hasn't been a lot of research done on this in the oculoplastics literature. There is one study dating back to 2009 where the authors did a prospective randomized clinical trial that included 16 patients with blepharospasm. And they used a little bit different concentrations that we use in our practice, but for them they defined low concentration as being 10 units for every milliliter injection, versus high concentration had 100 units per ml. And what they did was, for each patient, they actually injected one side of the same patient with the high concentration dose and the other side with low concentration. And then immediately after the injections, the patients were surveyed on the pain, bruising, and redness from the injection. And at their follow-up visits, which ranged anywhere from 1 to 3 months intervals, they were also surveyed on any complications or side effects from injections, the duration of the effect, and which injection side that they preferred. And so of these patients, majority were female, average age was 65. And one of the main findings that the authors describe is that the higher concentration injection side, patients reported significantly less pain with the injection. 58% thought that side hurt less, and they were surveyed on a scale of 1 to 10 for pain. So the lower concentration group, the thought is that if it's diluted with more volume and you're injecting more volume, that's possibly stretching the tissue more and causing more pain. And so that group rated pain about 4.5 out of 10 versus only 1.9 for the higher concentration group. So higher concentration group, again, that's a lower volume that you're actually injecting. In terms of some of the other outcomes they looked at, the patients reported no difference in bruising and redness from the injections, and no difference in side effects either. So they looked at droopy eyelid or ptosis after injection, double vision, and tearing and dry eye as well. And in terms of the length of relief of symptoms, the patients reported similar length of relief between the two sides, whether it was high or low concentration. I think half of them also said they didn't really have a preference for one side versus the other in this particular study. There's also several studies in the dermatology literature that haven't looked at blepharospasm specifically, but just kind of looking at what are the effects of varying the volume and concentration of a Botox injection in terms of diffusion of that neurotoxin through the tissue that you're injecting. So how much tissue is actually being affected by the injection. And so these authors also did a prospective randomized study that they included 10 patients, and they're specifically looking at the use of this for cosmetic purposes for forehead wrinkles. And so again, each patient received a single injection about 2.5 centimeters above their orbital rim, so the bone right above the eye, and one side got high concentration, one side got low concentration. And this is just from their paper and example of 2 of the patients. So in these patients, the right side of their forehead, which in the photographs is the left side, got the lower concentration injection, which again is a higher volume that you're actually injecting. And in the top photographs, those little white stickers are where the injection actually took place. And then the bottom photographs are the results 2 weeks later. And they actually measured the height and width of the area where the wrinkles were no longer visible in these patients. And they found that at lower concentrations, the toxin is affecting a greater area of tissue because you injected a greater volume in those cases. And so they measured, sort of in those bottom photos, you can see there's sort of less wrinkles visible on the right side of the forehead because the lower concentration kind of travels throughout more of the tissue. A higher concentration side, you can still see that the wrinkles more on that side because it's thought that if you give them a higher concentration, it kind of stays more focal right where you injected the medication. So our experience so far, these are just some preliminary results. Over the past year, we've been trying this double concentration treatment for our blepharospasm patients. We've done more of a retrospective study looking back on our 14 of our patients that have been treated with this. And once again, in our practice, we're defining a quote-unquote regular concentration as 5 units for every 0.1 ml, and a double concentration as 10 units for every 0.1 ml. In terms of some demographics, the average age of our patients is 70, majority are female, and on average, our patients have had a diagnosis of blepharospasm for about 16 years when we first tried double concentration on them. Many of our patients carry other additional diagnoses, so over 40% also have coexisting Mage syndrome. Some of them have apraxia of lid opening, and then a few also have coexisting torticollis as well. Just sort of went through all of the prior treatments that they've received. Obviously, all of them have received Botox injections in the past. Some of them have received Xeomin as well. Many have been on oral sedatives like lorazepam, clonazepam, or oral muscle relaxants. And then a few have also had surgeries, including myectomy, which Dr. Holtz gave a really nice presentation on earlier today. This is a chart just looking at some of the results we've found so far in terms of the follow-up and duration of treatment in the regular concentration group versus double concentration. And so far we've found the average treatment dose that each patient group is receiving has been similar, and the follow-up interval has been similar as well. So 10.5 weeks tends to be the follow-up period for the regular concentration group versus 11.9 weeks in a double concentration group. But what we found interesting so far is that the average duration of the effect was about a week longer in the double concentration group compared to regular concentration. We're just sort of going through this data and adding more data as people come for more follow-ups, but these are just sort of our preliminary results so far. In terms of complications, this is something that we really wanted to highlight. So in our regular concentration group of patients, they tended to report a more dry eye compared to the double concentration group. And this again, the thought is that with double concentration, you're not injecting as much fluid overall, and so that injection remains more focal in the muscle and shouldn't travel as much to cause more side effects. So that's sort of what our hypothesis is here. And so half of the regular concentration group reported pretty significant dry eye after their injections, compared to only 29% in the double concentration group. There were similar rates of droopy eyelid or ptosis and double vision between these two groups. Just a little bit more about our experience. As I just mentioned, 8 of the 14 patients, they reported an improvement in dry eyes, switching over to double concentration. Half of the patients that got double concentration, they said they had no side effects at all and no complications related to the injections. And then we did have 2 patients that were switched back to regular concentration, and that was due to some patients having difficulty closing their eyes or tearing. So just a summary of what I've talked about so far. So double concentration botulinum toxin injections, which we've defined as 100 units per milliliter, seem to result in less patient-reported dry eye symptoms. That's been a main highlight we've found so far. Higher concentration, lower volume injections may cause less side effects due to the fact that the toxin is not diffusing or traveling as much through the tissue and remaining more in a focal spot that you've injected. And then we found a fairly similar efficacy and duration of symptom relief between regular and double concentration, maybe a week longer relief with the double concentration group is what we've found so far. These are my references, and big thank you to Dr. Holds for organizing this today and also helping me with the presentation. Happy to take any questions as well.
Now, is this something that we talk to our injectors about? What they have been injecting us with and what options we have?
The question is this something that we ask our injectors about in terms of what they've been injected with already and what options that you have? And I'd say yes. I think obviously in every practice it's going to vary probably what concentration is being used, but I think most commonly, at least for the oculoplastics world and also neuro-ophthalmology world, that 50 units per ml is a pretty standard concentration that I've seen. And so I think it would definitely be worth it to ask your injectors if there's a different concentration that would be an option for you. Yeah, the other thing we found, so obviously with the, if you're using 100 units per ml, it's slightly more challenging to do the injections just because it's a very low volume that you're injecting. So in our syringe, you have to be very careful with the injection because it's a much smaller volume. And so, certain physicians may not necessarily feel comfortable doing that small of an injection. So I think it also kind of depends the experience of the injector as well.
2 quick questions. Do you think you met your objectives, if you will? And then would you consider this kind of bleeding edge, were you all the first to try it, or were you following research of other doctors?
Yeah, so I think a lot of what we've done so far is similar to that. There's only really that one study I mentioned in the beginning that's out there, but we're thinking of expanding this to include some of the other neurotoxins that have been talked about, particularly Juvo and Daxxify, which have been shown to kind of spread less in the tissue upon injection. And so we've actually also been talking about, could we try double concentration with those, or also just regular concentrations? That hasn't been studied either. But I think it's kind of the next steps of where we're heading with our study is to include some of the other toxins as well.
Sorry, one more thing. As an injector, would you prefer to be injecting a small amount and being more accurate, or a larger amount and having it spread? From your point of view.
So the question is, would you rather inject a small amount and have it be more precise versus a larger amount and have it spread? I think that depends what muscle groups that you're trying to target and what the goals are. So I think, you know, in our patient population with the blepharospasm, these are smaller muscles that are being targeted. And so the idea of being more precise and focal is helpful, especially in terms of getting less ocular side effects. I think possibly for a more cosmetic purpose, like in the forehead, sometimes you want more spread to get all those forehead wrinkles that are being treated. So I think some of it just depends on, you know, what the goal of the treatment is, cosmetic versus medical.